Now the next topic is nephrotic syndrome. Before we go into the nephrotic syndrome, we need to see the differences between nephritic and nephrotic syndrome. Difference between nephritic and nephrotic syndrome. First, nephrotic syndrome. Nephrotic syndrome, nephritic syndrome. Nephrotic syndrome, oh my god. So, increased risk, increased amount of protein. Increased amount of protein is lost. Massive proteinuria. Massive proteinuria, also lipiduria. By massive proteinuria, we get hypoalbuminemia. And which can also lead to edema. But the most common cause of edema is sodium water retention rather than hypoalbuminemia. Hypoalbuminemia is a cause, but most common cause is sodium and water retention. And thrombotic events. Thrombotic events occurs due to loss of antithrombin 3. Massive proteinuria is defined as loss of more than 3.5 grams per 24-hour urine. So we need to get 24-hour urine sample from the patient. In contrast, nephritic syndrome is characterized by mild proteinuria, unlike massive proteinuria. Here, mild proteinuria. Less than 1 gram per 24-hour urine sample. And the mnemonic here is HOHA. Hypertension. O means oliguria. H means hematuria. Hematuria, which is commonly called as cola colored urine. And A is azotemia. Azotemia is increased blood urine nitrogen. And for the naked eye, the nephrotic syndrome, in nephrotic syndrome, the specimen appears as frothy urine. Whereas for nephritic syndrome, it appears as cola colored urine or hematuria. With this basic differences between nephritic and nephrotic syndrome, let us jump into the basic general features of nephrotic syndrome. They are massive proteinuria, hypoalbuminemia, lipiduria, edema, and dilutional coagulopathy. It is also due to antithrombin 3 defect. Actually, coagulopathy occurs due to antithrombin 3 and also due to dilution. The urine is frothy here, and also it has lipid or fatty casts. due to the lipiduria. Now, after the general features of nephrotic syndrome, we go into the classification of nephrotic syndrome. Classification is based on the age groups in which the nephrotic syndrome is manifesting, and they are children, adults, and elderly. In children, it manifests as minimal change disease. In adults, it manifests as focal segmental glomerular sclerosis, and in elderly, it manifests as membranous nephropathy. And in minimal change disease, it has also got other names. Other names of minimal change disease are lipoid nephrosis or nil deposit disease. Membranous glomerulonephropathy. And under the general classification without the age group, we also get membranoproliferative. Glomerulosclerosis. No, glomerulonephritis. MPGN. It is also known as mesangiocapillary. Mesangiocapillary glomerulonephritis. Now let's come to children. Minimal change disease. Minimal change disease is caused by etiology. Etiology is unknown, but sometimes may be due to atopy. Or Hodgkin's lymphoma. Then age group 2 to 4 years. Clinical features: albuminuria or selective proteinuria. And due to the albuminuria, there is edema. After the clinical features, there are investigations. Investigations: under gross, it looks like a normal kidney. But under microscopy, light microscopy, electron microscopy, and immunofluorescence. In light microscopy, the name minimal change disease came because of the light microscopy. And the other name, lipoid nephrosis, came due to lipid deposition in tubules, mainly PCT. So we get lipoid nephrosis. And under electron microscopy, which is the gold standard. Electron microscopy is the gold standard in which we can see the changes, because also in immunofluorescence we see nothing, no deposits, because there is no immune complex formation. The electron microscopy is the gold standard, which shows effacement of podocyte food process. And now treatment. Treatment is steroids, which gives 100% response. With this, we move on to focal segmental glomerulosclerosis, which occurs in adults. So, it can be classified under 5 types based on the Columbian classification. Columbian classification, it can be classified into 5 types. They are focal segmental glomerulosclerosis, not otherwise specified, NOS. Next, glomerular tip, collapsing, perihilar, and cellular, in which the first 3 are important. Focal segmental glomerulosclerosis, not otherwise specified. It is the most common. Then glomerular tip. Glomerular tip has the best prognosis. Collapsing type is associated with HIV and has the worst prognosis. Then, causes of focal segmental glomerulosclerosis. Causes of focal segmental glomerulosclerosis can be primary or secondary. Primary causes are idiopathic. Secondary causes are 3H, 2R and IS. 3H, HIV, heroin, hypertension. 2R, reflux nephropathy, renal tissue loss or ablation or nephrectomy. And I is IgA, IgA or Berger's disease, and S is sickle cell anemia. In HIV comes HIVAN, HIVAN, HIV associated nephropathy. Then comes investigations. Under investigations, microscopy. Under microscopy, light microscopy, electron microscopy and immunofluorescence. Under light microscopy, focal and segmental. Focal means less than 50% involved. Segmental means only a portion of the glomerulus is involved. Under electron microscopy, there is effacement of podocyte food process. And in immunofluorescence, there is complement deposition. Now coming to membranous glomerulonephropathy or membranous nephropathy. And another point is that is more common in cancer patients. Its causes can be divided into primary and secondary. Primary causes are due to PLA2 gene defect, that is phospholipase A2 gene defect, or autoantibodies against phospholipase A2. And thrombospondin defect. And in secondary causes, it can be divided into A, B, C and D, in which A is autoimmune. Autoimmune, SLE and diabetes. Under B, which is bacterial causes, that is in general microbial causes, which involves hepatitis B, hepatitis C, malaria, schistosomiasis, syphilis and leprosy. Cancer, C stands for cancer and D stands for drugs. C cancer involves lung, colon, pancreas and melanoma. Drugs include gold, NSAIDs, penicillinoma. Penicillamine. Now after the causes, investigations. Investigations include light microscopy and electron microscopy. There is no immunofluorescence. So under light microscopy, we can use either Pass stain or silver stain, which is gomerymethylamine silver stain. Under electron microscopy, there are subepithelial deposits, spike and dome. So under PAS, that is periodic acid Schiff stain, there is diffuse glomerular basement membrane thickening. And in silver stain, there is spike and dome appearance. Also in electron microscopy, there is spike and dome appearance. But there are subepithelial deposits. With this, the classification gets over. I left out membranoproliferative glomerulonephritis or mesangiocapillary glomerulonephritis. In which there are features of both nephritic and nephrotic syndrome, but nephrotic syndrome features are more than nephritic syndrome. There are two types. So membranoproliferative glomerulonephritis type 1 and type 2. Type 1 is immune complex mediated, whereas type 2 is also known as dense deposit disease. DDD, dense deposit disease. This is due to C3 complement activation. C3 nephropathy. In immune complex deposition, they are of two types again. Two types, which is primary and secondary. Here also primary is idiopathic, whereas secondary is due to again hepatitis, schistosomiasis, alpha 1 antitrypsin deficiency. Now the microscopy, let it be common. In investigations, there is microscopy which involves light microscopy, electron microscopy and immunofluorescence. Under light microscopy, there is the use of silver stain, gomori methenamine silver stain, which gives tram track appearance. The tram track appearance is due to the splitting of glomerular basement membrane. Glomerular basement membrane split due to immune complex deposition. Immune complexes get deposited subepithelially. Subepithelial deposits. Now, in electron microscopy, based on type 1 and type 2, they are subendothelial deposits. And type 2 is dense deposit. And in immunofluorescence, there is granular deposit. Now coming to the genetic basis of nephrotic syndrome. On coming to the genetic base of nephrotic syndrome, we go to the morphology of glomerular the filtration membrane. The filtration membrane includes endothelial cells, basement membrane and podocytes, in which high power view of podocytes gives the following structure. There is a protein sticking outside called nephrin, and there is a protein inside called podosin, and there are two proteins inside, actin and CD2AP. This is of no use. The CD2AP is of no use. Podosin, nephrin and actin. Podosin is encoded by NPHS2 gene on chromosome 1. Nephrin is encoded by NPHS1 gene on chromosome 19, and actin is encoded by alpha actinin 4. Now, this genetic basis is now splitted based on the genes. They are NPHS1, NPHS2 and alpha actinin 4. NPHS1 gene produces nephrin. NPHS2 gene produces podosin. Alpha actinin 4 is actin. 1 is chromosome 19, 2 is chromosome 1. This one chromosome has not been specified. NPHS1 defect causes Congenital nephrotic syndrome. Congenital nephrotic syndrome, Finnish type. NPHS2 produces autosomal recessive focal segmental glomerulosclerosis, whereas alpha-actinin 4 defect produces autosomal dominant focal segmental glomerulosclerosis. It also causes NPHS2 gene defect causes steroid resistant nephrotic syndrome. And another gene has been given, which is TRPC6 gene, whose defect produces adult onset focal segmental glomerulosclerosis. And another one, APOL1 polymorphism, produces HIVON. And that is it for nephrotic syndrome.